healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome to another episode of Coffee with Coker. My name is Mark Reibolt, and I'm the host. And today's episode is one we do every year, usually at the end of the year or at the beginning of the next year. And it comes from a live forum that we did at Coker's annual meeting in early December 2019. And it was a panel discussing healthcare 2020. So we were looking at some of the things, the trends, predictions or things to look out for that maybe we can expect in the industry as it relates to either 2020 and beyond, but definitely wanted to drill down on some of those things that maybe the industry could look forward to coming up in the relatively near future. Well, we had a great panel. It consisted of three very experienced women in the industry that honestly it was just a great discussion, and I really value their input. So who we have on the panel, we have Dr. Stephanie Cross. She is an OBGYN and has many years experience both in the private practice setting as well as the hospital health system setting. Today she is a professor at the University of Tennessee health system, and she has incredible insight on her years of experience, decades of experience as a physician, clinician, as a partner in a group, and as an administrator in a health system, as well as in an academic environment. So Dr. Cross had great insight. We also had Roz Cordini, and she is a frequent guest, I guess, or has been in the past on the podcast. Roz is here at Coker, our Director of Compliance Services. Roz is both a JD and an RN and has a lot of experience in the health system environment and working on compliance matters, and she runs those services for Coker, and she also has invaluable perspective, and that's why I wanted her on this panel, because she really has her finger on many of the things going on in the marketplace, in the regulatory environment, in policy, healthcare policy, and as a result, she has great insight when we're thinking about some of the predictions for 2020. And then finally, we had Michele Madison. Michele has also been on the podcast before, but Michelle's great partner of Coker. She's actually, her actual role, she's an attorney, and she is actually a partner and one of the leaders of the healthcare group at Morris, Manning & Martin in Atlanta. And Michele has incredible experience, particularly representing hospitals, but also physician groups on a wide range of regulatory policy matters. Just has incredible insight on where we're at in the industry today, on some of the key trends and buzz topics, if you will, and kind of understanding what we can potentially expect in the future. So between Dr. Cross, Roz, and Michele, we had just an absolute great panel. I think everyone's going to enjoy it. We did have, as I said earlier, this was actually recorded in kind of a live open forum. And so we had questions from the audience, and some of the audio may sound a little bit different just because of that particular forum. And hopefully we got all the questions and the audio for those questions, or if not, then hopefully we were able to repeat them and specify what the questions were. But regardless, it was a great discussion talking about Healthcare 2020 with Dr. Cross, Roz Cordini, and Michele Madison. If you would like to check out some of our other episodes of the podcast, you can find all the Coffee with Coker episodes at coffeewithcoker.com. You can also follow us on all of our social media and for regular updates on new episodes that are coming out, as well as other content and research coming out from the Coker Group. So with that, I want to jump right into our panel with Dr. Cross, Roz Cordini, and Michele Madison talking about Healthcare 2020. Thanks for listening.
So what we're talking about now is we're just call it Healthcare 2020, and we're looking at some of the things kind of that's been going on in the industry, and but also some of the things that we're looking forward to seeing in the industry kind of next year and the upcoming years, and I think that's very relevant for everyone in this room and part of the company. So I actually just realized I'm the only guy up here now, so I feel really outnumbered, but that's okay. I want to introduce, and in fact, I'll let you all introduce yourselves, but Dr. Cross, why don't you introduce yourself?
I'm Stephanie Cross. I live in Knoxville, Tennessee. Go Vols, right? And grew up in Tennessee, medical school in Memphis, and I've been at the University of Tennessee Medical Center. I'm an assistant professor there and one of the core faculty members there. So I enjoy teaching residents and focus in minimally invasive surgery and catch a few babies here and there. So I'm here to talk a little bit maybe about boots on the ground medicine and what's happening. So thanks
Absolutely.
for having me.
Thanks for coming. Yeah, we appreciate that. By the way, my wife and Dr. Cross have worked together in Health Talents, which many of you hear about. That's a medical mission program that we're involved with in Guatemala. So Dr. Cross has gone a few times and contributed her time and expertise doing surgeries down there as well. So you'll hear a little bit more about that later. But Roz?
Roz Cordini, SVP over coding and compliance.
You guys know Roz.
And Go Michele? Louisville Cardinals. That's all I got. That's all I got.
Throw that out there. And many of you know Michele, but Michele, please introduce yourself.
Well, before I introduce myself, I always wanted to be an ESPN analyst, like well before I ever became an attorney. That was my dream.
We're making dreams come true.
Dreams are coming true this morning.
That's what Coker does.
Yeah. So I'm Michele Madison. I'm with Morris Manning in Atlanta. So I represent a lot of hospitals and healthcare providers in the Southeast. So yeah. Go Dogs.
Go Tigers. Michele and I have worked very closely on a number of clients, and she's worked with many of you as well. So we really appreciate Michele being willing to do this, all of y'all being willing to do this, but the opportunities we get to work with her. And then, yes, unfortunately, we have some Bulldog fans up here, but hopefully we can even that out. As we dive in, and you all be thinking about any questions you have as well. But what we want to do, as I said, just talk about kind of healthcare 2020. And one of the things I thought we'd do as far as just kicking this off is go down the line and just what are your thoughts on, it doesn't have to be anything overwhelming, but some of the things you think we're going to see in 2020 or kind of the next few years as it relates to the healthcare industry and what you all do and interact with on a day-to-day basis.
Well, I mean, my background, I joined a large group at the University of Tennessee because I just wanted to be a doctor and I didn't want to have anything to do with the business of medicine. And unfortunately, I must have asked too many questions because then I got stuck with the managing partner job for about 15 years, which was at least 10 years too long. But I learned a lot. I'm sure I made a lot of mistakes. And, just looking back over my 25-year career or whatever, just the change has been enormous. The double price pressure and just the things that we've had to do as private practices, and not huge practice, but we had 15, 16, 17 doctors and that sort of range. And that's still really not big enough to get a lot of traction when you're trying to contract and stretch that dollar. So, the math on it, and I think what we see everywhere, the consolidation and more physicians and physician groups becoming hospital employees, I think that's just going to continue. One interesting thing that I read and saw recently is how hospital systems, because 80% of outcomes for healthcare have nothing to do with what physicians or hospitals order or do. It's all the lifestyle factors, and how some hospital systems have started to recognize that and are going out into the community to look at things like housing and distance from grocery stores where they can buy fresh food. So and a lot of people, we just take for granted that we can go down the street and do that, but some of the places, underserved areas, and by zip code, even in Knoxville or any other city, the income levels vary so much, but the distance to a grocery store that actually has fresh produce is pretty amazing. And so a lot of hospital systems are starting to look at how can we partner with other community resources to try to solve some of these problems and actually make some steps and some progress with what everybody wants to see, which is value, which is outcomes, and starting to chip at that 80% of what we don't really do day in and day out. I think that's kind of an interesting topic that we ought to look at.
Absolutely. I do. I want to come back to that as well, because you mentioned a couple of things I definitely want to drill down on. Roz, what are your thoughts?
I think one of the things we'll see in 2020 and beyond is continued focus on costs of healthcare, particularly for hospitals. So I think we're going to continue to see more price transparency requirements for hospitals. And I think we're going to see more, or continue, but push out into the community. So more community-based care, home-based care, telemedicine, I think will continue to grow and expand who can be covered by it. And even, disruptors in the market, Amazon, CVS, Walmart, Lyft. I have a friend of mine who's actually one of the lawyers for Lyft, for their division that does pharmacy delivery, which is, so I think we'll continue to see that kind of activity, 2020 and beyond.
Yeah. Great. Thank you.
So mine kind of ties into both. From the hospital perspective, I'm seeing hospitals becoming more aggressive in trying to capture and clamor to get the physicians so that they can keep the patient base with themselves. And it used to be that the large hospitals were buying up the smaller hospitals, and we're starting to see less of that and more of a different kind of partnership. Or they're trying to say, let's take the smaller hospital and turn it into more of a ASC imaging center, and then we'll have our physicians service that center, but at the same time, we're going to try to employ more doctors at the larger hospital, and then they'll deploy them via telemedicine or other ways. And while that's happening, I'm seeing less doctors wanting to take call coverage. I've been living this nightmare for the last 2.5 weeks. So this concept of you're going to have a surgicalist in the hospital who's going to do all the surgery call, and you're going to have a GI guy that does all the GI calls so that my employed docs get to go home at 5:00 and they don't have call on the weekend. So that quality of life, we're kind of like Max. We don't focus as much on quality of life as far as going home at a certain time. I've answered some of those emails at 3 a.m. And so they are more focused on that quality of life side. The other part that I'm seeing are hospitals are more focused on the greater community and keeping the patients out of the emergency department that don't need to be there. So we have a paramedicine program that's spawned. I don't know if any of y'all have seen that in the Southeast, where the ambulances are not really ambulances anymore. They're more like all go-to vans. So they have some kind of EMS service in it, but they'll have a mid-level or an EMT who will go out to the home, and instead of picking up that person and taking them back to the hospital, if they can stabilize them in the home, they'll stabilize them in the home. And then it's not really billable from a hospital perspective, but it keeps the patient out of the wrong side of service and keeps the cost down, because that's the focus, is the shared savings. So it's lots of creative, innovative ideas of how do we service our community, but at the same time keep our costs down, and then how do we keep our physicians loyal to us. And I'm seeing more and more docs continue to be employed directly out of school versus putting out their own shingle.
Yeah. And I was actually going to ask about that. You kind of touched on it, but the generational dynamic that we're seeing in the clinical world right now, as far as the younger physicians coming up, and Dr. Cross, I'd love to get your perspective on this as well, but the maybe the differences in when you were coming out and going into private practice versus what you're seeing out of some residents and coming out of internships, things like that. You think that's fairly different?
Yeah. I mean, from my time to now, we definitely have seen that transition where they're more focused on quality of life. And there's a lot of healthy stuff about that. I trained before the 80-hour work week. So my 4 years were 110, 120 hours a week for 4 years. So there's more data that looks at physician fatigue and the level of impairment, when you get to the end of a 24-hour shift. And, I think as the public becomes more aware of that, there'll be some more push. Some of these residents come out after having an 80-hour work week, and if they do set their own shingle out, they actually work more in private practice than they do during their residency. But they are much more willing and much more interested in balancing that. And as long as they don't have unrealistic salary expectations, it works very well. And we have definitely seen in the OBGYN world the whole concept of hospitalist or laborist or that stuff and actually that's my job now. I changed from a pure private practitioner with a teaching appointment to now I'm a hospital employed OBGYN hospitalist, and we run those inpatient services in labor and delivery and the emergency surgeries and all that sort of stuff. So, and for me, it's been a great transition. Less of the gerbil wheel private practice production issues that everybody has to face. And it frees me up to do what I love, which is teach residents in the operating room. And I think it's, that concept when our chairman proposed that has just been a home run with the game theme here. For our residency program, they get more consistent teaching in the resident clinics and in the surgeries, even though they're still exposed to, 30 or 40 different faculty members in different subspecialties. So that whole, what they expect is, they're still very, very committed, but they're much more vocal, and there's less of that, suck it up and buttercup and keep running, which most of us did for a long time, which definitely isn't healthy. There's a balance there.
Sure.
You'll see a few that are unrealistic, and usually residency, and then as they decide what they want to do, then they start to realize, what that balance means from an economic standpoint and what their expectations are.
Well, on that, and Michele, you kind of alluded to this a little bit, but with some of the changing dynamics and how providers are functioning and how they're working, what do you feel like? Because we've been a part of those deals where it seems like it's just getting more and more aggressive. We're definitely familiar with those, and we got to push back a little bit even sometimes. But what are your thoughts as far as looking ahead? Some of are the expectations, whether it's compensation or benefits or incentives or production models, compensation models, do you think those are continuing to evolve? Are we really moving from a fee-for-service based model, do you think, or are we kind of just talking a lot about it?
So in the Southeast, I think we're talking a lot about it.
Sure.
We probably have 2 payers that are willing to come to the table and negotiate a value-based shared savings contract, very limited on certain service lines that they're willing to do that on. I think when we go to other regions in the United States, I'm seeing it more aggressive on shared savings. The compensation models that we've been seeing on the physician side is still your normal base salary, RVU. Here's a quality bonus if you meet these quality metrics. And we did start building in some shared savings because we're trying to create clinically integrated networks where we can go out and negotiate these contracts, and then they would get a share of that savings. The tricky part about that is getting the physicians engaged to set the protocols and then holding everybody accountable. My favorite CIN that we were setting up, the docs, we were all in this big room together. It was a single specialty CIN. And I said, all right, y'all are going to tell me what protocols you want on these specialties. And so they all brought the protocols, which was great. And then they said, well, what happens if one of us doesn't meet the metric? And I said, well, we have to have some kind of, you don't get paid this amount, or, maybe you go on a work plan. I didn't want to tell them you're out. So at the end, they're like, oh, well, no, we don't want any penalties, just upside. I was like, well, let's revisit this conversation. So it's a different dynamic. It's a different understanding. I think the doctors know that that's where there's great reward. Years ago, I attended a conference where the Indiana ACO was there, and they were talking about this shared savings program they did with Humana and this IPA that doubled what the IPA made by doing a shared savings on a Humana Medicare Advantage program. And the doctors in the room at that conference were all in. They were like, all right, let's call Humana. They're the first ones we're going to contract with. But you really have to look at what's your patient base, what's your quality metrics, where are you? So it kind of got stalled a little bit, but it's fascinating.
Yeah, so as we're thinking about, and again, looking ahead a little bit, and Roz, I'd love to get your perspective on this, and Michele too, kind of our attorneys speaking about this, that perspective. But as the burden continues, it seems like it continues to grow on the regulatory side of things, meaning it's just more complexity, more maybe just more uncertainty. What are your thoughts as far as what we can maybe expect out of the regulatory side of healthcare, whether it's truly regulatory or even kind of some of the stuff coming down on the legal action and OIG action, things like that? What are your thoughts for 2020?
Well, we have the proposed Stark Canine kickback rules that are hanging out there. And I don't know that it's going to do as much for value-based care and coordination as I think everyone hopes it will, because the rules are actually not consistent still. So there's still some gaps between the two. So it'll be interesting to see what they come up with in the final rule. There are some good things in it for care coordination and some subsidies that hospitals will be able to provide to independent physician practices around like cybersecurity and things of that nature. But So I don't think the regulatory scrutiny will end. And just to kind of jump off of something Michele said about risk-based contracts, one of the things we've seen in 2018, we've seen this year, are Department of Justice settlements surrounding Medicare Advantage programs where there is that shared risk. And so the physicians have a financial incentive to code and document a certain way. And the huge settlements, like $280 million, I think was one of them in 2018, were around ICD-10 coding and really selecting codes that were not appropriate for the care. And it comes back to the physicians ultimately because they had a financial incentive. So I think we'll continue to see a lot of scrutiny from the Department of Justice and OIG on those types of issues.
Yeah, I totally agree. They're very aggressive, and we're getting subpoenas all the time, civil investigative demand subpoenas with a list of patients that they want us to produce the records on. And they're usually, the ones that I've seen as of late are focused on use modifiers, so modifier 25, where you've got an E&M code, and if you bill for, most of y'all know this, but if you bill for the E&M code, it's got to be a separately identifiable service from what the other purpose of the visit was. And so they literally are running the reports to see who's an outlier, and usually it's our oncologist. So most of our oncologists are getting these CIDs. And then the focus of the medical necessity. I hate the words medical necessity, because when my doc says, well, what does that mean? I'm like, call Jeannie.
We like that answer.
Yeah. So it's hard. It's really hard. And the coding, and does the documentation support it? As much as we say that to the docs, you got to document. Then they get the EHR system that recommends, and I had this happen to a practice. They got a great EHR system that recommended the codes. And so they went with those codes because they checked all these boxes. But then the government came back and said, no, it should have been one level lower. And that's scary because they are relying on a clinical record system to help them. So they've got to exercise that. And I don't have a doctor that I've ever represented that understands CPT coding in its entirety or ICD-10 coding. So I think that we're going to continue to see that. The settlement amounts are gigantic. The Sutter Health case was gigantic. So I think we're going to continue to see large takebacks from the government, and that's not going to stop.
No, it's a great revenue source for them.
Yeah, right. They can't give that up.
Right.
One of the things, Michele, you alluded to earlier was like you talked about the paramedicine program, but and you mentioned this as well, but the whole telehealth, remote health, virtual health, whatever you want to call it, but the more commonplace that's is becoming, and I guess the more kind of accepted. Now this year, I guess it started where they're really notching up the coding opportunities and billing opportunities for those services. Maybe talk about kind of what we can expect there, whether it's technology in general, but specifically the kind of telehealth piece. And Dr. Cross, I'd love to hear from your perspective as a physician that's been in both a hospital and private practice setting, if that's something you really think is kind of to be taken seriously by the provider community, or if it's kind of slow going like everything else.
Okay. Well, where I am, we do have, for outlying regions, especially for things like oncology and even dermatology, a telehealth program. The problem has been, how do you bill for that? And it's a billable service, but the other problem is most of the insurance companies don't reimburse you for that. And so I don't think it's going to snowball until insurance companies understand some of the savings. From a patient standpoint, it's great. If it's just a quick follow-up, they don't need a physical exam. It's to discuss some results or something like that. It's an awesome opportunity for that person not to have to take a half a day off of work or to get a babysitter or this. There's a lot of convenience. And for a practice, you're not paying somebody, you're using your time, but you're not paying those 3 people who work that patient up, move them through the office. I mean, you really could garner some efficiencies if it ever takes off. I don't think it's going to be full stream, though, until insurance companies come to the table and start agreeing to reimburse physicians for their time. It's just like billing for phone calls. It's a billable service. It's more recognized than telehealth is, but a lot of private practices are hesitant to do it because they think it's going to hack off the patients, and patients are going to go somewhere else. So you're sort of caught in the middle. But I think it's a wonderful concept in certain scenarios, and for patients who don't have the ability or the resources to travel 2 to 3 hours, with some of these smaller hospitals, and this is happening in the state of Tennessee, are just going away. And so, we have 6 and 7 counties that have no obstetric providers, and these ladies are having to travel 2 and 3 hours for prenatal visits and ultimately for deliveries. And a lot of that stuff could be done with a mid-level in a local clinic and a telehealth communication with the physician when those patients develop problems. So I think it's a wonderful concept. And as a private practitioner, we looked at it and wanted to do it because it's convenient. You say, okay, fine, I'll do a couple of hours from 5 to 8 o'clock one night a week, and patients would love something like that. The problem is getting it paid for.
Yeah.
So that is the huge issue. It's the actual payment for that service. And even our insurance now, we have Cigna at the firm, and it pays for it. And my 12-year-old would be all about it because she thinks it's like FaceTime. So it's a great service if we can get it paid for. The way I see a lot of it being used right now to mitigate the cost for the hospitals is, so for example, there's a Rural Hospitalization Stabilization Act that came out in Georgia. We have probably 9 counties that don't have a hospital and have 0 primary care or OBGYN physicians in them at all. No physicians. So what they did is they put the telemedicine in the ambulance. So when the ambulance gets called, they go out, they use the telemedicine to then go back to the doctor. So Dr. Jean Sumner, who's the dean at Mercer, she's a family practice doc out of Washington County. She's all about telemedicine. And she did that demo for the legislative delegation. And it was fascinating to them because they had no idea that you could use a stethoscope and really hear just as if you were sitting there with the patient because of the Bluetooth stethoscope. And then she looked in their ear. They had a mid-level on the ambulance, and she could look in the ear and tell that they had an ear infection and it was a child. And so she could diagnose that, and they could send in the prescription because it was an antibiotic to that CVS that was in that area. So it's a great service, and it's one way of reducing cost, but getting it paid for, that's critical. And the other part is a lot of times we use it in school-based clinics to keep teachers and students in school. So the nurse can use it and the doc can be at the hospital. And that is actually getting paid for as an originating site visit for Medicaid. So if you go to a school where the child may be eligible for Medicaid, Medicaid will pay for that service. And then Medicaid came out, or the government came out and said, we're going to audit all these telemedicine payments to see if you documented it appropriately. And it's like, okay, so that's stressful.
Yeah.
But I think it's great technology. I think it's improving every day. And I think if we can get the government to pay for more services via telemedicine, we can address some of the physician shortage issues that we have, not all, but we can at least make healthcare more accessible to areas that don't have it today.
Great. You joke about your 12-year-old, but my 12-year-old would be the exact same, and she would figure it out how to do it before I would, as far as working with the technology. And the reality is, I think, though, their generation is going to expect that, and that's going to be the norm more so than it is probably for our generation and previous generations. So I have to think that's something that both on the government side as well as the private commercial payers, as far as getting on board with, if they're going to kind of keep up with the next rising generation, if you will, that's going to make a lot of sense. One of the things we heard a lot about, it seemed like in 2018, possibly even before, but leading into 19, was a lot of discussion around the opioid crisis. And I know working in the Southeast, Roz working in Kentucky and West Virginia and Appalachia, and Dr. Cross in Tennessee. I don't feel like I hear as much. I know a lot has been done. I don't feel like I hear as much buzz as I did maybe last year or the previous 2 years. What are y'all's thoughts as far as where are we at with that, and should we expect more?
at least, on the ground, we still see a ton of it. And in Knoxville, Appalachia, the numbers are huge. The NICU rates, those babies who are born to opioid addicted women, those kids withdraw, they stay in the hospital sometimes 20 to 25 days. We have one of our maternal fetal medicine specialists who works with a substance abuse clinic, and the Tennessee also puts law in the book about reporting where women could theoretically be prosecuted. And what we saw initially is people were not showing up for prenatal care because they were afraid that they would be prosecuted. And physicians don't agree with that, obviously. So we don't, we just try to help patients, but we still have huge numbers. That maternal fetal guy has actually started a program where if a patient's very, very motivated, he will actually taper them off. The standard has always been just to leave them on Subutex or methadone, and it was based on very little data where the fetus would be at danger if you tried to withdraw them on slowly. And he's shown that you actually can do that safely. The big problem is even if you get them off successfully, but they go back into the same scenario. If you look at addiction rates and relapse rates, even if the problem is paying for treatment, and that's where we need to focus instead of trying to pay for prosecution for all of these folks, because, the relapse rates are horrible. These children are not normal. When you look at them hitting their milestones, these babies are not normal. So we're going to have a generation of people that are going to be extremely affected by this. And, what happens too is the country feels like it needs to do something. So they have a screening database. It's just more clicks that we have to go through to check to see if this person is, doctor shopping and has multiple prescriptions, and limitations on the number of days. And for post-surgical patients, they might need more than 3 days of a narcotic. But there's a lot of stuff that makes it difficult. And a lot of things, I think the answer is, how do we figure out treatment? And how do we keep these folks sober and not throw them back into the same scenario? 28 days of inpatient treatment, which it's very difficult for most of them to have any of that paid for. They don't even have that option, So I think figuring out in healthcare industry, insurance companies, we need some help with figuring out how to treat folks to give them even a chance of success. And when you look at the costs we had a maternal death a month ago on a girl who came in, was an IV drug abuser, and they come in with they're septic, they have valve vegetations, and she was already septic, even though she made it in the hospital with a pulse, but still it is a huge problem. And you look at the inadvertent overdose rates too. They don't know what they're getting. There's a lot of synthetic drugs that look exactly like Percocet or exactly like a hydrocodone, and that come in from China. And so that's where a lot of the accidental overdoses come from. Yeah. So still a huge problem.
Yeah.
I would say from an enforcement standpoint, it's really the pharma companies that they're going after. Yeah. And I think we'll continue to see that next year. Still do see, there's still some bad actor prescribers out there. So you do see the settlements with those folks who are actually prosecutions and going to jail and things of that nature. But I do think in 2020, we'll start to see more focus on treatment. Already Medicare has some treatment programs. I've lost the acronym for it, but certain programs that they'll pay for. It's really like methadone type treatment programs, which I guess there's a lot of mixed feelings about those types of programs. But I think we'll continue to see more focus on those types of programs to try and address it. Another issue I think hospitals have and physician practices have, every state has different local rules on prescribing regulations for physicians. And from a hospital standpoint, because the opioid crisis is still a big focus on enforcement, really looking at your employed doctors and their prescribing practices to see, are they actually meeting the regulations? Because when these regs first came out, it was kind of like, well, it's your license. If you want to not follow the rules, it's really going to ultimately hurt you, which it will. But now that there's so much employment of physicians going on, it's going to come back up to the employer to say, you should have known that your physicians were not, or mid-levels, not prescribing appropriately.
We actually audit that in our compliance programs we develop for the hospitals. It's one of our standard quarterly audits, the PDMP report. Are they documenting? Are they looking? And just 2 weeks ago, so I was in North Georgia, the docs, we had a medical staff meeting, and the Department of Community Health had sent out an email letter to them with the report of where they stood in relation to their peers. And it was shocking to them. Like the doc said, I'm not going to write another C2 again. I was like, well, you got to kind of treat patients.
Yeah.
But they were very alarmed of where they fell. And I think it's really sometimes the region where you are. We've got a huge issue. And then what is appropriate and what are you documenting? It's not that it's totally improper. It's how do you treat the patient? So, but these reports scared these docs really bad. But the PDMP is supposed to improve at least the knowledge of what the patient's doing and where they're getting drugs. The issue, I think, there's there's a big chasm right now because there are some substance abuse programs. I was in DC, and the substance abuse programs don't report to the PDMP because they have the ability to protect a patient when you're enrolled in a detox program. That's a Part 2 program. So their information's not in the PDPM documentation. So that's kind of a big missing part if they're doc shopping. So anyway, so the opioid side is still going to be a big area. We handled a DOJ case related to a hospital compliance on pharmacy and discrepancies and missing drugs. And I had multiple cases going with the Department of Justice at that time. Of course, all the clients were innocent. But during that time, I had several that were pending for months at a time. And this opioid case came up. And we of course cooperate always with the government. And so when we met with them, they said, this is our number one priority case. And we literally got it settled in 6 weeks. I had had cases pending for months, and that one was done in 6 weeks. So they're working on that. It's still a priority. It's the first time I've ever had a DEA agent cell phone number, and which is a nice thing to have at the end of the day, honestly, because you have a doc who has a question about can I, shouldn't I? And he was super helpful and super nice guy and would answer my call on a Sunday. So not all DEA agents are bad. He was
there you
good.
go. Well, I always say, and I think, I've said it multiple times, and I think, Michele, you and I have even done presentations tying to this, but yeah, I feel like the majority of the doctors that are out there are not pill pushers, obviously, and they're not even egregious about if they are kind of a little bit outliers. I think a lot of it is they're surprised. They don't know really where they stand against their peers, and they're pretty surprised. A lot of it is also just, even if they're everything's reporting very good, the lack of documentation. And that's one of the things we look at when we go in and do alignment transactions, hospitals and physicians, employment, what PSAs, where it may be, when we're looking at from a due diligence perspective, what documentation do you guys have? And when you get into the chart audits and you get into the compliance reviews and coding, looking at coding practices, billing practices, it's not always there. And so even if they are doing it well, you got to document it, you got to show it, you got to prove it. And the burden of proof seems to be one of those things that's going to be continued emphasis there. By the way, any questions, please feel free to raise your hand, and we'll make sure you can ask questions directly to the panel. But I guess also, as we're thinking about, we touched a little bit on technology as far as telehealth. Do you have any thoughts on, are we still talking big technology changes like in the industry, like we heard last year, even earlier this year, the whole Warren Buffett, Amazon, JP Morgan kind of project? I'm not sure exactly how that's evolved or where it is now. But as not only have we seen consolidation on the provider side, but consolidation on the technology vendor side has really seemed to impact the industry. What are y'all's thoughts going forward? Is that something we think, we're going to be looking at 2 or 3 vendors here pretty soon? Or are we still kind of out there with dozens and dozens, and that's going to be kind of the nature of the beast? Any thoughts?
We're looking at 2 or 3 vendors.
We are?
Yeah. I mean, you could look at a state and you could name 5 vendors, maybe tops, and I think we'll get down to 3. On the physician side, there's more because people have gone for some different systems, but I still see those consolidating. So the big thing that we're running into is a lot of sunsetting of programs that hospitals or physicians have purchased, and they're getting sunset. We had a large system get a sunset letter on Monday, and we literally bought that program 18 months ago.
Yeah.
And it wasn't cheap. Yeah, somehow that didn't come up during due diligence on the deal. That's scary. And then the other part is we had one that sold a nice piece of equipment to a large facility, and it had Windows 7. So that was a small problem. So that was a little frustrating. So making sure the due diligence is done correctly, but I do see us seeing more consolidation.
Yeah, I think so. And it's been, on the physician side, just that, it's so obvious when you move through a certain company. I'm on my 5th EMR now. Wow. And I said I'd never do it again, but I'm co-chair for our hospital's conversion to the Power Chart maternity product of Cerner. But I know I've done it so many times. I know that if, you don't work out some of the kinks on the front end, it's just horrible for everybody. So it benefits me to get things as smooth as possible. But you can tell when you're in one of these systems, there's glitchy things where they bought this part of that program and this part of that, and they try to roll it together. And even coming from a Power Chart or a Power Works, which is a Cerner product, rolling into Power Chart maternity, that data doesn't transfer. It doesn't come across. I think an interface is possible if it's, everything's HLA 7, but it's either too cumbersome, half the stuff doesn't pull across, and, that turnaround on stuff like that's incredible. The amount of work that it takes for staffers to go in and front load things before we can even see patients is amazing. And so I agree. I think there are going to be probably 3 vendors by the end of this, by the end of the whole thing. And I don't know what the timeline's going to be, but it's really difficult to work through it from a hospital system standpoint. And when you're just living in the clinical world trying to get your patients seen, and not go home every night in your pajamas and try to chart 30 patients that day. Yeah.
I think the big thing as we're putting new systems in is the build. So I was telling Terry this earlier, depending upon how much resource the hospital dedicated to the project and who was at the table when the build happened makes night and day difference. I have one hospital where they had the IT director and they had a handful, maybe 5 people that worked on the build, and they missed like 90% of the revenue cycle department in that discussion. I'm like, problem.
Maybe important.
Slightly piece, problem. Yeah. We realized that after 90 days and no dollars coming in. So the build part, I think, is critical. We have a tiny little hospital who has a CEO. She's lovely. She's an Auburn fan, but she's lovely.
There are a few of those out there.
Yeah, there's a couple. So she is she's a bulldog by nature, but she's a tiger. But she was all over this company, and she had her entire team, because they're small. She had her entire team involved in the build. Their first bills that went out, they got paid like right away. That is my only hospital that did it quite that, but they were small. And I have other hospitals that just didn't think the build was important, and they really paid for it later. So as you guys are working with the hospitals on the IT side, the build and the due diligence ahead of time, unbelievably valuable.
I'm sure there's a few people in here that would agree with that and support that. So
yeah.
I think we had a question.
This is great. Thanks very much. And all of you guys' expertise. Community hospitals and access to care, rural hospitals. We do a lot of work with those types of entities. And Michele, I was particularly intrigued with your comment. I didn't realize that. I think I heard you say 7 counties that know such care. Nothing. That's a real problem in this country. Some think that the solution to that is single payer, universal health care of sorts, where essentially the government will step in and provide that care. So I'd love to hear your comments on that, as well as it relates to our firm in serving the rural hospital and the rural patient. And obviously this spills over to the provider, physicians, and APPs as well. Well, what's your thoughts at warp speed? They're all in many cases, from 1 year to the next. So love to hear your comments.
All right, so I don't want them to go away because I have 34 of them.
We'll
and I have young children. So it is a huge problem, though. So the single payer, My CEOs have mixed reaction to that. The first reaction is never, never, never. We must have competition. We must have multiple payers. We need to have that. And there are times when they're not getting paid or their contractual allowances are such a huge cut that they're like, well, maybe we need a single payer who will pay us on all these services. But they very rarely do I have a CEO that says he wants that unless we're in a huge crisis. Most of my rural hospitals are scared in one way or another. We had the rural tax credit, which for those of you that have seen that program, it's where you pay your state taxes and you can allocate it to go to a rural hospital if it meets certain criteria. And it could go up to $4 million for a rural hospital. So last year, and this is just in Georgia, last year, my hospitals loved that. That made their bottom line. Not that they made a profit, but it covered a lot of the cost. At that time, you were allowed to take a federal deduction when you donated that money from the state side. Well, that's gone. The IRS said we really weren't supposed to let you do that. So now this year, they've seen about a 70% drop in those dollars. So as we go to these meetings, they are completely scared of how am I going to make the bottom line now? We have a big payer issue on the rural hospital side. We have no leverage. And so the payers are saying, we're going to narrow our network and you may not be in, and we might just have to have you transfer your patient to this less costly imaging center or to this hospital that we've negotiated these great rates with. I literally met with a payer 3 weeks ago who told me that they had a lab place within 30 miles of every location because they weren't going to pay the hospitals for that service. And I said, but you understand the number one issue in this rural area is transportation. They can't go 30 miles. So if they can't go to the hospital for their lab draw, they're not having their labs done. And we've got a healthcare issue at that point. So I think bringing the payers together with the rural hospitals to show that there is an advantage to the payers to have the rural hospitals that have lower rates. I have rural hospitals that their charges are way below the larger hospitals. So they could do a percentage of charge and still pay less and get a quality service like labs or imaging or outpatient surgery, things that the rural hospital can really focus on. So I think I would like to see the rural hospitals survive, obviously, personally. I love my clients because most of the time they are the largest employer in that community and they're the nicest people. When you go to the board meetings, it's the banker, the chamber guy, the pastor, the lady from Board of Education. It's always somebody in that realm. And they genuinely care about their community and you just want to help. So that's why it's so rewarding to work with them. And they're also an economic development driver. So when they sent out reports last year, $89 million in one small county was because of that hospital, because the textile plant wouldn't be there if they didn't have a hospital. So the Chaparral boat place, they wouldn't be there if there wasn't a hospital near. So I think that they're economic engines for the state. I think we have to protect them. And I think we have to bring payers to the table with the rural hospitals to make it work. And then I think we have to partner with the larger hospitals on staffing because they can't afford to pay the employed docs that the larger hospitals can do. So the larger hospital will partner with them on staffing. And it could be mid-levels. It could be physicians. It could be clinics that they do joint ventures on. I think that supports the larger hospital and the smaller hospital. So that's a lot to say, but did I cover your question, Max?
Yeah, you went for Congress.
Exactly. Yeah, I agree. It's it's a shame those communities suffer because transportation is one of their biggest things. Driving 3 hours for something, even a simple office visit, is just it takes an entire day. I'm very fiscally conservative in general, but the more I look at what we see, this is the richest country in the world, and we still have such a huge number of people that either don't meet criteria for Medicaid coverage and they're just not getting care. The 50-year-old breast cancer patient who came in who had stage 4 mets everywhere, and there was a certain amount of denial there. But this lady was a single mom, works in a factory, doesn't have insurance coverage, and literally she came in when her bone pain was so bad she couldn't stand it anymore. And that kind of stuff happens all the time. We see that all the time, and the insurance companies don't address it. There's this big gap in care, and the rural hospitals going away, I think, would be a tragedy. But I think the other part of this, short of a single payer, which makes me sick to say it, but the physician side of me almost feels like we're never going to close that gap if we don't finally go to something like that. And then the whole theoretical thing of what happens to biggest building in any city is usually owned by an insurance company. What happens to that whole industry if you really go to a single payer? And again, so the thought of it scares me. The thought that the federal government could actually do anything efficiently completely scares me, because some of the Medicaid, hoops that we have to jump through are idiotic. But personally, I just don't know short of that. I can't even dream up an idea that would close that gap like probably a single payer would. So I don't know.
Roz, you spent a little bit of time in community hospitals. What do you think as far as is the pressure continue to escalate?
Well, first of all, I don't think in my lifetime we'll see a single payer system. And I'm not that old. But I
got a long ways to go.
I'm old, but not that old. Because I agree, the government is just so inefficient in our country. I think we have to protect the rural hospitals, but I think ultimately it's what I said earlier. I think we're going to see more home-based care. We're going to see more telemedicine efforts. I think that's going to be how the access to care is provided in some of these areas that don't have any health care. Notwithstanding, transportation issues are a huge problem if they need, care other than home-based or telemedicine driven. So,
yeah. Question, Terry.
You raised an interesting point early on when you talked about outcomes and then putting the patients having to go back in that environment. What do you see in your opinion on these population health systems that providers can use to help identify patients that are really in critical need and that they get all their preventative care and colonoscopies and all of that? Just to make your opinions on those, please.
I think they're effective if you can get them paid for. And I forget which hospital it was. I read this a long time ago. But they actually have a program. They have a high rate of diabetes in their service area. And they developed a program where they actually go door to door doing some basic education, but identifying people who may have, diet issues, exercise issues, need help getting their lab work done, things of that nature. So I think if you go into the community and can deliver care in their community where they don't have to go in, some of them won't drive in even if they could. Yeah. They won't take the time. They don't believe it's an issue. But so I think population health is absolutely important and effective, but we still have payment issues. So
I agree. I think identifying them and then actually having the intervention early, kind of like what you were saying, then they're not in crisis when they walk in the door. It's a lot less costly. They're also getting coupons from the super Walmart that has the grocery store so that they can use those coupons to be able to get the food. The other big thing are pharmacy prices. When that commercial comes on with the nurse or the waitress that brings her kids into the pharmacy and she can't afford the meds until they give her the coupon, I cry every time. It's like a Hallmark commercial. So that issue is real. And so they're focused on what kind of discounts can they get and can they identify those coupons for the people ahead of time. But it takes a lot of technology and a lot of work to identify those patients. I've seen a couple of models. I've seen hospitals that have hired part of their hospitalist service will be just following up on the patients that were discharged because the transition codes, they could get paid for that. And then they have like the paramedicine program where they would send out a mid-level or a nurse to the home if the patient had a transportation issue to intervene with that patient or get the meds delivered to them. So it's rare because that takes a lot of resources, but I've seen that program. And then we've worked on a deal where we learned that there is a physician practice, big primary care. They have an overlay on their IT system that identifies those patients for them. And they send out the nurses to the home to care for those patients and to do the wellness visits and then bring the information back to the docs. And honestly, at the end of the day, when we did the analysis, the docs made a lot of money on that deal because they identified a lot of other procedures they could do. And that generated more income for the practice.
Yeah. And in that case, accounting for production under a hospital model was, there was another layer of complexity there as far as the billing incident too and all that. So, which makes me think, and again, think of questions if you all have them, but one of the things, I think Dr. Cross, you may have alluded to it earlier, but one of the big things that we do a lot of is related to transactions, and talked about consolidation a little bit. I literally a few years ago remember saying, all right, this has got to slow down. We're at the point where it's got to start ratcheting back a little bit as far as the number of deals, valuations got to start coming back. I was very quickly proved wrong, obviously, because it continues to go up, it seems. I mean, meaning these deals continue to happen. The valuations have gone up, and kind of the structures and the terms, not just the enterprise valuations, but truly kind of the whole economic package involved in some of these deals. Where are we? What are your thoughts as far as where we are in that whole dynamic? And then also considering what are some of the drivers? For instance, I think private equity getting into some of these markets is really spurring activity. And that spurs activity with the hospitals. And of course, many physicians are weighing a number of options. You also have the Privia, right? The Privia model, which is something that we're seeing much more pervasively as far as growth there and kind of what they're doing, and other systems, other companies doing similar things. Thoughts on consolidation as we look at 2020?
I mean, I don't think there's definitely different areas of the country that have different rates. At least in Tennessee, it's still happening at a breakneck pace. We're behind Atlanta comparatively, but I just think the arithmetic of private practice, from somebody who slugged it out every year trying to find insurance, our own insurance for my 70-person organization, every year we were having to nibble at this and nibble at that. And, your reimbursement goes down all the time and your costs go up. And the group that I managed in this last year has now done that transaction with the hospital. And it was a group that was started in 1973 and was, fiercely independent and fiercely private. But there's a point where the math doesn't make sense for a private practice unless you're a mega group, one of these mega multi-specialties or even mega single specialties. But, you have to have a couple of hundred doctors to make that make sense. And so I don't think the consolidation thing is going to stop, because I just think the math, the accounting of running that kind of business, it just doesn't make sense. You can only save $1 once, and there's a point where it's all red, and you have no choice. So I thought before I took this job, I took the job I took because it's, it answered so many things for me, but still, you have a little bit of regret with seeing kind of what happened with that practice. But I told them, afterwards, I said, 10 years ago, guys, we sat around the table and I said, at some point, we're either going to work for a hospital system or, God forbid, we'll be working for an insurance company. And I just don't think there's a way around it unless you're some mega group, unless there's some other. And I lived through the early 90s when the private equity groups were coming in trying to buy practices, and then they'd have a 40-year contract, and literally you had to leave the state to get out of it. They didn't have the tracking in place. It was and hospitals did that too back in the 90s, and they didn't have the right metrics for following. They would promise the doctor these, crazy numbers based on their billing, not based on their revenue, and all that fell apart. And they shed a lot of those doctors off, and now I think they've come back and with a much more workable model. But I don't think it's going away.
I don't either. I think it'll continue. I just think acquisitions and consolidation will continue.
Yeah.
I'm surprised by the multiples the PE guys are throwing out.
Yeah, that's one of the things we've worked through. Is hospitals competing with private equity, and they have a different, to a certain extent, set of rules, or not as strenuous rules to follow, and they make big promises, so it looks really good sometimes on paper. One of the things we've talked about is, what about the stuff that's not clear on paper? When you go beyond the economics, you go beyond the numbers, start really thinking about what is the dynamic here. And I think, there's different motivation, different providers at different stages of their career may even go into those opportunities with a little bit different perspective. I think we had another question.
Yeah, I had a question. From this pure patient care delivery perspective, are you happy with that consolidation, hospital physician consolidation, or do you think it's a better model having it separate?
So the question was, from a patient delivery standpoint, has that consolidation gone well? Are we happy with that? Has that been successful, or would a private practice model make the more sense?
Right.
I mean, in my case, I am happy with it. And I think it depends on the contract that you have with whatever that entity is, and my contract is based on some of my salary comes from the Graduate School of Medicine from a teaching standpoint, and the rest of it comes from university health systems. So it works for me and it works for the other physicians that I work with. I think some of the private practice practitioners that, in that group that I was with, for them, they're still very, they're pushing on them from an RVU standpoint. I just don't think you get away from that. So I don't think that we in my location have seen any negative impact in terms of patient care and being able to provide what you thought was necessary. Whether the hospital signs your paycheck or whoever, ultimately that revenue thing is always, you're fighting it out with the insurance companies, whether you work for a hospital or whether you work for yourself as a private practitioner. So,
Roz and Michele, the clients y'all worked with, you think those have been pretty successful, have been pretty happy, or should we be expecting some separations?
I mean, I think globally, physicians in general are very happy to not be burdened with the day-to-day office operations, and they certainly are making more money employed in a lot of cases than they were independent. Sure. But I do hear, especially at the early stages, just a frustration, a lack of control over how things are being done, a lack of, being able to direct all the activity within the office can be a little frustrating. But I don't think they're going to unravel anytime soon.
I agree. I think the benefit for the physician of not dealing with the administrative burden and the cost and looking at, okay, I've got this new registration person that's going to cost us this much. We're going to need to see this many more patients. I think the benefit of not dealing with that day to day is nice, but what I hear is communication, because the docs owned their own practice. They ran their own practice. They knew what happened on a day to day basis. And now there's this big hospital and they've got a VP who's supposed to communicate with them on a monthly basis. And that's not enough information for them. And so they feel that loss of control. And that's where we get a little angst. So trying to build up a physician governance committee inside of a hospital when they employ physicians, so you have a physician liaison to speak to, so you have that constant ability to communicate, I think helps to keep that sustainability.
Yeah. Again, it goes back to kind of getting beyond the economics. I think sometimes they're just looking at the dollar signs initially, and then only after the fact, they think, oh, well, this is really going to change the way I've done things for maybe 30 years or the last 15 years or whatever it may be. Yeah. I think we had another question over here.
Yes. I realize we have an LSU person on the
Go
panel.
Tigers.
So I'll go Dogs, so I'll speak slowly.
Thank you. It's much appreciated. We spell things really weird too.
Right. So I enjoyed your comments about value-based reimbursement, but that's not where my question is. As a nurse working in rural hospitals, critical access hospitals, I was really taken back of the patient's low expectation of care and access. And I don't know if you've run into that. It's not my question. But it was just from a patient advocate standpoint. I actually had someone from a board of a small hospital say, well, we're not Atlanta. We can't provide everything. And, we had to bring it back and say, well, patient care doesn't cost. The caring part doesn't cost any more than it does in Atlanta. But the interesting thing, the word that I've heard a lot today is one, you said fear of, closing. And then I think with the opioid crisis, physicians have a fear of prescribing, but then conversely, a fear of not prescribing for the patient if they're expecting to get treated or if it's an appropriate treatment. What do you think? And this may require Max to do a white paper. I don't know, but this answer. But what do you think that the government can do to alleviate the fear? It's just fear everywhere, and that shouldn't be associated with healthcare. I know that's a huge answer.
It's a great question. And I don't know what the answer to that is. I think it's legislatures, the buzzword, it's the topic of the day, and they feel like they got to do something. So they throw a law on the books, which may make sense to them, and they may call a few docs about it. But in the end, it doesn't generally address the wide variety of clinical issues that we have. One of the laws in the state of Tennessee is for pregnant nursing women, you cannot write a prescription for longer than a week for a narcotic. And, there are some things that sometimes patient actually needs something for more than a week. So I think, I think they need to spend more time going after the less than 5% of the people with a prescription pad who are the problem, rather than creating a whole nother, another layer on what I call the creep list. It's another thing that we've got to deal with. It actually interferes with our ability to care for people. And you see that in nursing with the multiple, things that have to be documented, 12 different forms. I mean, there's a lot of duplication and a lot of waste of time, and there's a lot of click fatigue that goes along with that. And so I think it's well intentioned, but when they create these new systems or these new requirements, I don't think they have the right players in the room where it happens when they try to build that model. It's the same thing that you see time after time after time in multiple issues. So I don't know what the answer is. I know what the difficulties are. But I think they're going kind of after the wrong things, trying to address that need, and that, hey, we are working on this. Yeah.
I can't imagine tying clinicians' hands behind their back just because of the actions of a relatively small percentage is not going to be a good thing.
Right.
It's not going to work.
A lot of times that legislative arm that drafts those, I'm not sure the government's the answer to that issue. I think a lot of times when I read some of the bills that are proposed, I'm like, who wrote this, and have they been in a hospital in the last 30 years? So I get very frustrated.
Probably not.
It's kind of like yelling at the TV. So I'm not sure that that's the answer. I do think that you've got to have more engagement from the people that will draft the laws with the actual people who are the providers. And I think there's a huge chasm there. Even when I look at the committees that the government puts together, there might be one doc, there might be an IT person, but there's a lot of policy people and not necessarily the person who's at the bedside. The other thing on the expectations of care in rural hospitals, I have a hospital that I love. It's a 5-star. Love this hospital. They have amazing patient volumes just geographically where they are. In order to get out of that community, you got to go over a mountain, so you might as well go to the hospital. But their chief nursing officer has drilled quality into all of her staff, and the people in the community, they'll go to the churches, they'll go to the Dollar Generals, and they'll do health fairs talking about the quality of care in that hospital, and everyone trusts it. And when they walk in the door, they're not going to Atlanta. They're going to stay right there because they don't have to go over a mountain to get to Atlanta, but they're going to stay right there because it's great quality. So a lot of it is community education and having them understand that we're not your last resort, we're your first stop. So,
Roz, on that question, as far as fear goes, I know you work with a lot of hospitals on compliance and groups on compliance matters. So is it, some of the discussions we have, I kind of start wondering the same thing. Like, is the pressure to the point of fear getting so burdensome for these organizations from a compliance standpoint, covering all the bases, dotting all the I's, crossing the T's, or all that, or is it manageable? And I know you're a big proponent of, hey, get ahead of this stuff with a good compliance program, and we can really thwart a lot of this. But I mean, is that the situation most are in, or are we kind of at this kind of chaos or fear level?
I think it's different. Hospitals are generally much more advanced in their compliance efforts than physician practices are. And in fact, most physician practices that I know of or work with or have friends who own them really don't do much in the way of OIG compliance. They might have a plan that's on the shelf. They don't really fully do everything they need to do for HIPAA, other than the notice of privacy practices. And So, what was the first part of your question?
Just is the fear growing? The pressure growing?
I think there's not really that much fear, other than those providers who are receiving, governmental payer audit letters, or they get the CID, or, something happens, then all of a sudden it really rises up here. And then hopefully they're calling us to come help them set up their program. Yeah, but no, I really don't see a real high level of fear in physician practices. I don't know if you agree.
So it's manageable. Yeah. I think we have one more question and we'll have to wrap up.
I just wanted your opinion on site neutrality. law? One, do you think it's going to actually be repealed? And two, how do you think that's going to affect hospitals?
So the question was about net neutrality, site neutrality, which is the idea that the billing practices, the disparities between a hospital and a group or an outpatient setting, that many hospitals have enjoyed a lot of benefit over private practices over the years, is in theory or could be leveled out to a certain extent. What are y'all's thoughts on that?
I think they're going to continue to level them out. My hospital's argument is I have to be accredited with a Joint Commissioner, a DNV, and my cost to be accredited at the levels that I have to be accredited are much higher. My staffing matrices are different than you have in a ASC or a physician practice. And so they feel like my reimbursement should be higher because my cost is higher. At least that's what I'm hearing from my CEOs, but I'm continuing to watch their reimbursement decline. And obviously hospital-based clinics are under the OIG work plan now, and they've been under it for before. But, it used to be the hospitals would purchase the doc's practice, put it near the hospital, bill it as a hospital-based clinic. And those are getting audited so often now. And that's part of our compliance programs. And our hospital is to audit that quarterly as well to make sure or annually actually on that one, to make sure no one's messed up on the criteria for integration. And most of my hospitals now, so maybe 5-6 years ago, they would have made them hospital-based. Now they just bill them as a clinic under Place of Service 11 because their reimbursement really isn't that different.
And I agree. I don't think it will be repealed. I think we'll continue to see it. And there's certainly hospitals have enjoyed, that improved reimbursement. So I think the pressure will continue. And like I said earlier, I think the whole cost equation for hospitals compared to, community-based centers and practices is going to be a focus, and they're going to continue to expect reduction in cost or actually push it through legislation.
Well, yeah, and it's been very common for us as we've worked on either side of a transaction, whether it's representing a hospital buying a practice or representing the group. It's always been that argument of, well, the hospital has so much better rates and makes so much more than we do, so they can certainly afford to pay us more, right? Well, first we have to explain that's not how it works as far as determining compensation and valuation, but also it's not necessarily. I mean, I think we worked on one, Michele, that when the hospital kind of looked at it, said, we're really not going to make that much more, if any. And of course, we know there's a expected loss on their physicians, employed physicians already. So it goes back to the cost thing. But yeah, I think that's something to definitely, they're going to have to figure that out. I think it's also, this would be a whole other discussion, but bringing in CON laws as well. I mean, if you're going to take the gloves off on outpatient billing, then what about, opening that up as far as hospitals and CON states being able to do more of that, which could, change a little bit of that dynamic as well.
Yeah.
Well, I think that's all the time we have. I really appreciate you all contributing. I think it was a great discussion. Let's give our panelists a round of applause.